Good afternoon. Thank you so much for joining us today. We're so happy you could be here with us. My name is Tamara Bingham Noyes. I'm the Director of Business Development at Center for Change. I'm here with Megan Austin, who I was going to say Austin and awesome at the same time. Megan Austin, who is one of our awesome dietitians at Center for Change. I'll tell you more about Megan in just a minute. We're happy that you all could join us. We have a couple of things that we need to do really quickly before we launch into Megan's presentation. So you'll see some information on your screen that will be helpful throughout the broadcast. So first, a copy of the PowerPoint is in the handouts section of the toolbar. You're welcome to take a look at that. You can also download it so that you can look at it later. Obviously, Megan will go through the PowerPoint slides as she goes through her presentation, but if you need a copy of the PowerPoint, it's found there in the handouts section. A copy of the post test is also in that same handout section of the toolbar. This is for reference only. To obtain continuing education credit, you must take the post test online, and I'll talk about that in just a minute. You're welcome to submit questions in the questions section of the toolbar. We'll try to get to a few of those at the end of the webinar, so I'll keep an eye on those throughout the presentation, and then at the end, we'll see if we can answer a few before everybody has to go. When the webinar ends, there's an evaluation that will pop up on your screen. If you would take just a minute to complete that evaluation, that would be really helpful for us. That's a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in that feedback. We then tabulate those results and send those to the CE entities. So if you would take just a minute to complete that when it pops up at the end of the webinar, that would be helpful. And then about an hour after the webinar ends, you'll receive a separate email from GoToWebinar. It will look similar to the email that you received when you registered for the webinar. The second follow-up email about an hour after the webinar ends will have a link in it to take the online post test. And again, you must take the post test online in order to receive continuing education credit. Once you pass the test online, then the certificate is automatically downloaded to your computer. So keep an eye out for that. If you don't see it on your screen, check your downloads file on your computer. Sometimes it hides in there. Okay, with that being said, we're going to launch right into the webinar. We're so happy to have Megan Austin with us. As I said, Megan is one of our amazing dietitians at Center for Change. She's been with us for over 5 years, and she is the primary dietitian on our interdisciplinary diabetes team. We have a treatment team specially for the treatment of type 1 diabetes and an eating disorder, and Megan is the lead dietitian on that team. She's very knowledgeable about eating disorders and diabetes and how those two things can work together and also be difficult. And she's going to talk more about that today. She's conducted research with some of the patients at our center and others about type 1 diabetes and did that as part of her thesis. So she'll be talking about some of the results of her thesis today. So with that, I'm going to turn it over to you, Megan. So give me just a second to click this and get it over to you. Okay, it's coming your way.
Okay, so we practiced this. Hopefully y'all can see my screen.
I can see it just great. Yep, you did great, Megan. Okay, I'm gonna bail out. I'm gonna turn off my mic and my camera, but if you need me, I'm right here, and then I'll pop back in at the end. So take it away.
All right. Okay, thanks, Tamara. Like Tamara said, my name is Megan Austin. I'm a dietitian here at the center. I've been here a little over 5 years, and I think it was either my first or second year sometime, the dietitian who was working with our diabetes team left, and I volunteered and kind of got thrown into the deep end. We had 5 patients with type 1 at the time, and learned on my feet quite a bit. So I've really enjoyed working with all of our patients, but especially our patients with diabetes, and have learned a lot. So we'll go through, and just as I go through these slides, since my professor and I are still working on preparing our manuscript to submit for publication, so I wasn't able to provide handouts and things with our results. So I did try to highlight in red with asterisks anything that may relate to some of the post-test questions. So if that helps to kind of bring your attention to things as we go through the webinar. So like Tamara said, this presentation is based on research I did as part of my thesis. I recently went back to Brigham Young University and got my master's in nutrition science and did a thesis as part of that and just finished up this last spring. So today we'll be going through some background information about eating disorders and diabetes, an overview of the research that we conducted, the results of that research, and then kind of our findings and applications, and then a little conclusion. So today, hopefully by the end of this presentation, you'll be able to describe some of the unique needs of patients who have this diagnosis of EDDMT1, which is eating disorder diabetes mellitus type 1. So you may have heard the term diabulimia before. That one's used a lot, especially in the media. And so we use this term EDDMT1 because it's a little more inclusive of anyone who has an eating disorder and type 1 diabetes, whether or not they skip insulin doses as a purging behavior. And then second, be able to explain the importance of having an interdisciplinary treatment team and what their roles are when working with these patients. And then we'll dive into our findings about what the current practices are and what we believe are areas for improvement or future research in a residential eating disorder treatment setting. So a little background, probably everyone participating has a different amount of exposure to diabetes and to eating disorders. So we'll just go through a couple basic things for some background information. So type 1 diabetes is an autoimmune disease that destroys someone's beta cells in their pancreas, which means they can't produce enough insulin to handle the food that they're eating. And so in order to manage their blood glucose levels, they do have to take insulin for the rest of their life because there is currently no cure for type 1 diabetes. Diabetic ketoacidosis, or DKA, is a potentially life-threatening condition if someone has untreated high blood glucose levels. So probably most commonly, someone may go into DKA when they're diagnosed with diabetes, and that may be part of how they find out they have diabetes, is that their blood sugar levels are going really high, because if their body isn't producing insulin and they're still eating carbohydrates, their body's not able to get the glucose from their carbs into their cells. And so blood sugar levels stay really high because the glucose is all in their blood and not in their cells. And their body starts producing ketones to be able to function and meet its needs, and so can be pretty serious and scary with altering some pH levels in the body. And so it does require a hospital visit, and so someone may have that when they're diagnosed. If someone is intentionally skipping insulin doses, that may be a sign. We'll talk about that in a couple slides. And then A1C, or hemoglobin A1C, is a blood test that we use to estimate blood sugar levels over about the past 2 or 3 months. And so you can kind of see down here for someone who doesn't have diabetes versus someone who does have diabetes, what is typically recommended or normal for them. And then a little background on eating disorders. So the DSM-5 defines anorexia nervosa as restriction of energy intake that leads to a significantly low body weight. There's intense fear of gaining weight or persistent behavior that prevents them from gaining weight, even though they're currently at a low weight. And a disturbance in the way in which one experiences his or her own body weight or shape, excessive influence of body weight or shape on self-evaluation, or persistent lack of recognition of the severity of their low body weight. And so typically when people think of anorexia nervosa, they think of someone who's really underweight and doesn't eat enough, which is a lot of the patients that I see with anorexia, but we can also see someone who may be in a larger body with restrictive eating behaviors that would be diagnosed with anorexia. There's also 2 subtypes. So there's restricting type, or someone who may restrict but then also have periods of binge purge behaviors. And the DSM-5 categorizes how severe anorexia is based on their BMI and how underweight they are. And then we have bulimia nervosa. So the DSM-5 defines this as recurrent episodes of binge eating, recurrent inappropriate compensatory behaviors to prevent weight gain. So some of those compensatory or purging behaviors may include self-induced vomiting, misuse of laxatives, diuretics, medications, fasting, excessive exercise. And the binge eating and compensatory behaviors both occur at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur exclusively during episodes of anorexia nervosa. And then they define the severity of bulimia by frequency of behaviors. So those are kind of the two main diagnoses I wanted to highlight today. That's what I personally have kind of seen the most as far as diagnoses go with the patients with type 1 that I've worked with. A little bit of background on this ED-DMT1. So the research shows us that those who have type 1 diabetes, or I guess women with type 1 diabetes, have a 2.5 times higher risk of developing an eating disorder than their peers without diabetes. And so we'll talk in a minute about why they may be at higher risk, but we do want to be really aware that this population is at an increased risk of developing an eating disorder, and hopefully we can provide more education to other providers, families. I have an outpatient with type 1 who started to engage in some disordered behaviors. Mom got her in for an outpatient appointment within a couple weeks, and so she's been able to stay on outpatient and do really well. But I was even talking about this increased risk with her, and she had no idea someone with type 1 was at an increased risk and why I would be concerned that she was counting calories or doing different things. And so I think even among those who are diagnosed with type 1, I think there's a lack of education of maybe how certain behaviors may impact them or lead to an eating disorder compared to somebody else. The intentional skipping of insulin doses is a unique purging behavior for someone with type 1 diabetes. And so sometimes they'll eat, whether that's eating appropriately or maybe binge eating, and then they'll skip insulin so that their body's not able to utilize the nutrition from that. They'll basically pee out all the glucose that they ate, and it will cause really high blood sugars, but is a way that someone with diabetes can try to manipulate their weight. It doesn't come without consequences, which we know omitting insulin, the research shows us, is associated with a 3-fold increased risk of death, increased rates of nephropathy, and higher rates of foot problems when compared with those who do administer appropriate amounts of insulin. So they are, if they're skipping insulin doses, they are at higher risk of some diabetes complications. We also find that longer residential treatment stays are associated with better outcomes for this patient population. But there hasn't been a ton of research on specific recommendations for clinical practice. Kind of like I alluded to in the last slide or two, those who do have type 1 are at a higher risk of developing an eating disorder. And this is believed to be caused potentially by weight gain with insulin initiation. So a lot of people, when they're diagnosed, they lose weight and then they start using insulin. And because they're actually able to get that glucose into their cells, their body's able to absorb and use all of the nutrition from their food. And so they can gain weight pretty rapidly after using insulin. There's also sometimes some edema associated with starting insulin that may be temporary, but if they don't know that, they think they've gained even more weight than what they lost before they were diagnosed. And so that, for someone prone to an eating disorder, can be pretty triggering. Diabetes educators or practitioners or dietitians or whoever may recommend a certain amount of dietary restraint. They may encourage limiting carbohydrate intake or rigidity around carbohydrate intake, which can make someone more susceptible to disordered behaviors. And like we talked about, skipping insulin doses is a unique behavior that someone with diabetes could use to lose weight or control their weight. And so some warning signs that someone with diabetes may have an eating disorder or have this diagnosis of ED-DMT1 would be an unexplained increase in their A1C. So if they're skipping insulin doses and their blood sugars are staying higher on average, then we'll see that A1C, which is that 2 to 3 month average, also be higher. I know we've worked with a lot of patients who come in with A1Cs of 14 or higher, and they recommend with diabetes try to keep it under 7, so it's a pretty significant difference. Repeated episodes of DKA, so that diabetic ketoacidosis. If someone is skipping insulin, having higher blood sugars, they may go into DKA and be in and out of the ER frequently. I've had patients who never really go into DKA, even if they're skipping insulin, and I've worked with other patients that are in the ER monthly with DKA. And so hopefully we can also educate practitioners in other areas like the emergency room that would be a red flag that maybe someone does have an eating disorder and we could refer them to the appropriate resources. Extreme concerns of body shape and size, so similar to patients without diabetes, lots of focus on weight and shape and weight loss. Excessive exercise and hypoglycemia, so exercise typically increases one's sensitivity to insulin, and so can get glucose from the blood into the cells better. And so if someone isn't eating and fueling appropriately for that with diabetes, they may exercise and then have a low blood sugar. And then very low calorie meals or the absence of menstruation, similar to patients without diabetes, are also going to be a warning sign of an eating disorder. If you don't work in a residential eating disorder treatment space, you may not be as familiar with what that looks like. It typically involves living full-time in a non-hospital setting, includes meal support, individual and group therapy, and multidisciplinary treatment. So here at the center, our residential patients, they do live here full-time. Their day consists of going to all their meals and snacks, sitting in group therapy, participating in group therapy, having individual sessions with their dietitian and therapist, meeting with a psychiatrist and medical practitioners. So basically they live here and their full-time job is treatment. And then that multidisciplinary team may include psychiatrists, therapists, psychologists, a physician, nurse, dietitian. We have care or psych techs who work on the units full-time with our patients and attend meals with them and groups with them and just monitor for safety and things on the unit. And like I mentioned, I think earlier, longer treatment stays in residential levels of care have been associated with better outcomes in those with type 1 diabetes and eating disorders. And so typically, my experience has been most insurance companies are kind of understanding that when you also have diabetes, there's more medical complications and we need more time monitoring and supervising, but sometimes can be a challenge if insurance isn't approving them to stay as long as you as the treatment team feel they need to stay, and maybe putting them at risk of a higher risk of relapse by discharging before they're ready. And then there's also been some studies interviewing people with EDDMT1, and what they found was that patients with EDDMT1 reported feeling more hopeful about treatment and recovery when their eating disorder and diabetes were addressed simultaneously while in a treatment facility. And so if they're at a residential eating disorder treatment facility, their eating disorder, everybody knows how to treat the eating disorder that's there, right? And so they feel like those needs get met really well. I think sometimes it can be hard if, I know some of our patients have expressed frustration, whether at our facility or another facility, if the nursing staff doesn't know a lot about diabetes, or maybe they don't understand how their diabetes technology works, or just to have a higher or low blood sugar and no one really knows what that's like. And so I think when you have enough education, whether you have diabetes yourself or not, I personally don't have type 1 diabetes, so I haven't experienced a lot of things that our patients have. We have a couple treatment team members who have type 1 themselves, and so they have a lot of street cred with our patients. But I think just getting more education and understanding helps you to have more sympathy and empathy for these patients and be able to talk to them in language that they understand and connect with in a different way than maybe some of our other patients who don't have diabetes. And so, like I mentioned earlier, there really aren't published standards of care to treat EDDMT1 in a residential setting. There's no, gold standards or maybe recommended treatment practices. And so that was part of what led me to, in my master's, want to do more research about this. I'd really enjoyed working with this patient population for a couple of years here at the center, and really wanted to know more about, you know, what information is out there, what are people doing to treat these patients, what's working, what's not working. And so that was kind of what maybe inspired the question of wanting to know more about this. And so for our research, I obtained a list of a little over 300 eating disorder treatment facilities in the United States from the Alliance for Eating Disorders Awareness, and then went through that list and had some exclusion criteria. So I excluded facilities if they weren't located in the United States. There were a couple listed in Canada or some US territories that we excluded. If they didn't have an active website or contact information and we couldn't get a hold of them, we had to exclude them. If it wasn't an eating disorder specific facility, they were excluded. So some of the facilities on that master list were maybe a behavioral treatment facility or a substance abuse treatment facility that also took patients with eating disorders who had maybe multiple diagnoses, but we wanted to focus specifically on eating disorder specific facilities. And then we also excluded any facilities that didn't offer residential care and focused more on what's happening in residential treatment. Some of the facilities or clinicians listed were just an outpatient practice or a PHP or partial hospitalization program where they weren't living there full time. So after all of that exclusion criteria, there were 104 eligible facilities. And so with the help of some research assistants, we made over 4 rounds of calls and emails trying to get in touch with the clinical nutrition director or manager or lead dietitian at the facility to see if they'd be willing to participate and tell them a little bit more about what we were planning to do. And so initially we had planned to do a survey over Qualtrics online and have people answer questions about all of the things we wanted to know about their treatment practices. And so we created a survey tool. My professor and I did some cognitive interviews where we had a few participants on a Zoom call going through the survey live and thinking out loud and giving feedback about that survey. And as we did those cognitive interviews, it was pretty clear that they wanted to be able to explain things in more detail. And a lot of their answers weren't so black and white that they could answer yes or no or give a clear answer, that there were always qualifiers of, well, in this situation, or we've done it a couple different ways, or it depends on the patient. So we decided to shift gears and turn that survey into an interview. And so I conducted all these interviews over Zoom, and our goal was to, since we were planning to do qualitative data analysis, we wanted to reach data saturation. And so really just getting to a point where we were starting to get repeated answers and we weren't really finding anything new. And so when we reached that point, we had done about 19 total interviews. And so we interviewed the clinical nutrition manager at 19 different facilities across the country. And the interview guide also had 19 items on it. And so you can see some sample questions here. We tried to make the questions a lot more open-ended so that we could get really rich data and get a lot of information from the participants. So things like, please describe the nutritional philosophies of your facility's treatment program. How would you describe the insulin therapy process at your facility? Things like that. And then if they were confused or unclear or not answering the question because they were confused on what the question was trying to ask, we'd ask some probing questions and provide some clarification. We also did send them a short demographic survey. So there were some questions that were a little more clear-cut that we wanted to know. So we knew what these facilities were like. And so we did send that out in a survey format, things trying to gauge how large the facility was, what their patient population is like, And I conducted these interviews in the fall of 2020, and so we asked about how many patients with EDDM21 they had treated in the prior year. And then the last question of the survey provided them with information so that they could schedule their interview with me. And then each interview was about 30 to 60 minutes over Zoom. We recorded audio and video, and we transcribed word for word every single interview. After going through all of those, we did decide to exclude one interview due to bias. One participant didn't know a lot of the answers and needed help to understand and answer things, and so we felt that it maybe biased the data that we got. So we ended up with 18 total interviews after transcribing and excluding the one. And then we did compensate all the participants with a gift card to thank them for their time. We used a case study design for our qualitative analysis. So if you're not familiar with that, we had 4 researchers, including myself, that we read all of the interview transcripts and then met together to identify a descriptive framework. And that framework was basically trying to come up with different categories or topics that we could use to organize each participant's experiences into consistent and coherent narratives. And then once we had come up with those, that descriptive framework, we, myself and another researcher, used that framework to create a case description for each participant interview. So we took these multi-page long interviews and condensed them down into about a 1-page summary, using that descriptive framework to pull out the information that that we wanted to know and that we felt was important. And as we did all of this, you know, initially with interviews and then with these case descriptions or these 1-page summaries, the 4 researchers, we all immersed ourselves in the data. We read and reread and got really familiar with them. And then we met together again to identify uniform categories. And so the uniform categories, you can see a sample here. One of our uniform categories was suggestions for improvement. So we came up with about 14 uniform categories that from those summaries, we pulled out information for each of these uniform categories and created these word tables. And so you can see the participant, 1 through 18 are on the left, and then whatever their feedback or information that's related to that topic is there. So you can see here suggestions for improvement. Number 1, they said they didn't feel like they had enough resources for their team. You know, number 5 didn't give any suggestions. And so we just pulled out whatever information was relevant for each of those categories and had 14 total in a word table that we made for each one. And then once we had those word tables, we identified 4 themes. And so the themes, we created 4 themes that we felt those 14 uniform categories could all kind of be categorized within. And so the 4 themes that we identified were nutrition interventions for patients with diabetes, medical diabetes management, interdisciplinary diabetes team, and then the clinical nutrition manager's assessment of diabetes care. So our first theme, some of the results that we found when we asked about nutritional philosophies, most of the facilities reported using an all foods fit or health at every size, intuitive eating type approach to their counseling, or trying to encourage more flexibility, trust, and balance with their eating. The weighing practices didn't differ too much, but participants did report that they would do a weight exposure more frequently with someone who has diabetes, since they are attending very frequent medical appointments and have a higher likelihood of being exposed to that number. And so they wanted to be able to prepare them for that and process that with them. The facilities on average had 3 meals and 2 to 3 snacks per day. Most facilities used an exchange-based meal plan. If you're not familiar with that, it's kind of loosely based on the diabetes exchanges, and meal plan guidelines are given more in terms of certain food groups and how many of those servings you need at each meal and snack. to make sure their nutritional needs are being met. And then patients were allowed to plate or portion food under supervision at some point during treatment. And there were some different approaches, but most dietitians reported some type of monitoring of their carbohydrate intake. So some dietitians reported having target ranges. Maybe it was based on like the AMDR recommendations, where 45 to about 60 or 65% of their calories were coming from carbs. Maybe limiting or having a certain number of carb or starch exchanges at their meals, or having carb counts, those types of things. We asked about supplementation and tube feeding practices, but for those who did offer those things, they typically just used the same supplement as the patients who didn't have diabetes. And so it wasn't very common to have a diabetes specific formula for either supplementation at meals or tube feeding. Our second theme was all about medical diabetes management. And so we asked about continuous glucose monitor, or CGM, and insulin pump use. So if you're not familiar with those, a CGM is a device that a patient will wear that monitors what their blood glucose is throughout the day and the night. So they don't have to just do a finger stick to find out what their blood sugar is right now. They can have that being monitored throughout the day. They usually have a reader, or maybe it's connected to their phone, where they can scan the device and be able to see those trends and patterns. And then insulin pump is also a device that someone with diabetes will wear that can deliver insulin so that they don't have to do injections or things like that throughout the day. It also allows them, rather than just doing one injection of their long-acting insulin for the whole day, to kind of have some background insulin being delivered all the time and then giving insulin in the moment for their food. And so most facilities reported if a patient had previously used a CGM or an insulin pump, they would allow them to bring it with them to treatment, but they wouldn't provide those for them. One program said that they require all their patients with diabetes to get a CGM before they'll let them admit. And so for the other facilities, if they didn't use CGMs, they used just a finger stick so they could check blood sugar in the moment. A lot of the facilities that use CGMs also reported using finger sticks as needed, or in conjunction with the CGM. Blood sugars, they did allow patients to check those under nursing supervision, typically at some point during treatment. That differed a little bit facility to facility. Most frequently across facilities, blood glucose was checked before and after meals. And then a lot of them described having a gradual transition of patient responsibility. So they may come in and have the nurse be managing their diabetes, and then eventually they're able to do more of their own diabetes care before discharge. There was one clinical nutrition manager who reported that they sometimes would not supervise insulin management or administration by their patients, and that they would just have that be self-reported. Insulin regimens varied a little bit. Obviously, that varies patient to patient, but typically patients were receiving some type of long-acting insulin and then getting insulin in the moment with their food, more of a bolus insulin. And so they would use a carb to insulin ratio for that, and often would be provided with carbohydrate counts so they could dose appropriately for what they're eating. And then as far as managing blood sugars that were out of their target range, they reported that if they had a high blood glucose, they would typically just treat that with insulin. They would maybe have a lower carb meal if their blood sugar was high, but typically would just use insulin. And then for a low blood glucose, they would have some type of fast-acting carbohydrate, so things like juice or glucose tabs, things that will bring the blood sugar up quickly. We asked about their practices in monitoring A1C, and A1C was primarily the only lab that was really different between patients with and without diabetes. And that was typically only checked at admission at most facilities. And then with urinary ketones, across facilities was not checked very regularly, but if it was checked, it was usually just done at admission. And then only 2 of the participants identified any specific diabetes complications that they screened for. So things like neuropathy, retinopathy, any kidney problems. And so only 2 of the participants identified any specific complications that they do screen for at their facility. There really wasn't a difference in how patients with diabetes participated in movement or exercise while in treatment, but most participants did say that it would require them to have medical and dietary approval so that they would be appropriate for exercise, which would often mean their blood sugars were pretty well managed, and they may require them to bring some type of fast-acting carbohydrate to the movement group in case of a low blood sugar. So our third theme was all about the interdisciplinary treatment team. And so you can see here who each participant reported was on their treatment team. And the dietitian or nutritionist was the most frequent and consistent member across facilities, which is part of why we chose the clinical nutrition manager as the person that we interviewed, because we felt that this would be consistent across facilities and that they would be involved in some way in working with patients with diabetes. And if they weren't sure of certain practices, they could reach out and would know who to ask about those questions. So dietitian, probably primarily, also therapist, medical and psychiatric providers, nursing providers. You can see down kind of at the bottom, one facility reported having, it used to just be the CDE, the diabetes educator, but they've recently changed that credential to the CDCES, if you're not familiar with that. So the diabetes educator that you've probably been familiar with in the past, but only one facility reported employing a CDCES, and then most facilities reported working with an endocrinologist, but more in a consultant capacity rather than having someone as a facility employee. So the clinical nutrition managers that we interviewed were obviously very knowledgeable about nutrition interventions. The amount of experience that they had working directly with patients with diabetes varied quite a bit. 5 of the participants had never personally worked with a patient with diabetes. And so they had treated patients with diabetes at their facility, but it was either maybe a coworker that was the primary dietitian on the treatment team or something like that. There was a very apparent knowledge deficit related to medical practices, insulin regimens, blood glucose management, things like that. A lot of the dietitians were unsure or didn't know and didn't feel comfortable answering any questions about how these patients' blood sugars or insulin management was approached. The dietitian was heavily involved in diabetes education. And when asked about which topics were most commonly covered, they reported that they talked a lot about insulin. So whether that was them or a medical provider talking about the function of insulin, dosing practices, the consequences of manipulating insulin, the relationship between weight and insulin. They also talked about blood glucose, how to manage out of range blood sugars, the importance of stable blood sugars, what target ranges should be, the impact of eating disorder behaviors on blood sugars, and then also talked about things like the role that carbohydrates play in our body and why they're important, or weight history and how their weight has changed with insulin and things like that. We also asked about any diabetes-related therapeutic topics. So things that were commonly addressed were talking about the stages of grief and how that relates to accepting your diagnosis of diabetes, diabetes burnout and fatigue. It is a chronic health condition, and so there is a lot of burnout. Diabetes etiquette, so just meaning kind of how to deal with maybe uneducated or insensitive comments that other people may make to you about your diabetes or your insulin or your food or carbs, these types of things. Eating out with diabetes, the effect of the eating disorder on their diabetes, insulin safety. I've worked with patients before where overdosing on insulin is part of a suicide plan or something like that, and so we're very careful about making sure our patients can commit to be safe with their diabetes care and that they can administer insulin appropriately so that they don't end up in a really risky situation. Gaining independence with diabetes management, especially with adolescent patients, finding balance, preparing for endocrinology appointments, and general relapse prevention. We also asked if the facility provided any diabetes-specific groups, so a group specific for people with diabetes to talk about diabetes. And none of them reported doing this and stated they didn't want to single anyone out, or they often didn't have enough patients with diabetes at the same time to have a group together. So our fourth theme was about the clinical nutrition manager's assessment of diabetes care. So 6 of those interviewed didn't identify any strengths. They said things like it's a work in progress, or, you know, we have things that we're trying to get to, but didn't identify any current strengths. Of those who did, things that they highlighted as being strengths at their facility were their medical management, the way that their team communicates and collaborates, and their ability to individualize their patient care. And then only 1 clinical nutrition manager had no suggestions for improvement. But of the rest who did identify areas for improvement, they talked about improving or increasing education for staff, having more formal diabetes treatment policies to reference, stronger medical support, having a diabetes educator, a specialist on their team, and having quicker access to labs and blood glucose logs from their patients. So we'll dive into kind of our thoughts and our takeaways and how it applies to clinical practice. So we talked about nutritional philosophies. So a lot of people talked about using intuitive eating or an all foods fit approach, things like that. And so we identified some potential pros and cons. So pros being that they had increased flexibility and less emotion-driven eating. And research has shown that there's worse glycemic control or higher A1Cs when they do have emotion-driven and disordered eating behaviors. And so we thought that that would be a pro. It would allow more flexibility, less rigidity around their food, but potentially may be more challenging to eat intuitively in situations where eating may be dictated by insulin or blood glucose levels. So I know I was just talking to a patient yesterday, an outpatient of mine, who she had a low blood sugar. She had been following her meal plan, had a low blood sugar, and she panics when she gets a low blood sugar and is really scared of her blood sugar going dangerously low because she is a single adult and lives with roommates, and so a lot of her diabetes management is up to her. And so she has a really hard time doing 15 grams of carbs and waiting 15 minutes and all these textbook things that sound really nice and work well, but she typically will eat or overeat a lot of high carb foods and have a rebound high blood sugar. And so sometimes it can be tricky if there are situations outside of their control that may dictate when or how much or what they need to eat or take insulin for. We thought that the exchange-based meal plans were likely well suited for patients with diabetes and could provide a solid basis for carbohydrate counting. If they're estimating about how many carbs are in each exchange and they know what their guidelines are, it would work really well for estimating and dosing insulin. And we know that carbohydrate counting is associated with improved glycemic management. So not that it has to be exact and precise, but if you're doing some type of counting and estimating and dosing your insulin off of that, your blood sugars are likely going to be in range more of the time. We talked about pros and cons of using diabetes technology. So using a CGM can provide more complete blood glucose information. So not only can we see what is your blood sugar right now, but how is it trending, and can provide estimates of maybe my blood sugar is technically in range now, but it's dropping. And so I need to do something about that. It can, using a CGM can eliminate or decrease the need for finger sticks, which none of us would probably like to poke our finger multiple times a day to figure out our blood sugar. So I think helps improve quality of life. Similarly with insulin pumps, it decreases the need for injections. I've worked with patients with diabetes who have fear of needles, which seems really ironic, but you know, is something they have to face multiple times a day, every day. And so this can lessen some of that burden. And using a pump can potentially allow more flexibility with eating. So some of my patients who use pumps that are trying to be more intuitive and flexible with their eating, we may dose insulin for part of their meal at the beginning, and then at the end of the meal, when they see whether or not they finished 100% or 85%, or how much of that they actually finished, they can complete dosing for that, so that it's not, oh, I dosed for 100% of the meal, I felt full 90% of the way through, but I have to keep eating because I dosed for that many carbs. Some potential cons of using diabetes technology: that constant information may contribute to some obsession and perfectionism around diabetes numbers. We've worked with some of our patients to check their blood sugars less, which maybe seems like bad practice, but they're so obsessed with it, they're checking it constantly all day long, and it's not helpful for their recovery. And then staff at the facility may not be very familiar with diabetes technology, so it would require extra training and education. One concern, a big concern that I have, was that not all patients were being supervised while administering insulin and doing these diabetes cares, which allows a lot of opportunity for potential mismanagement or abuse of diabetes care and insulin, and could allow for some manipulation of insulin. Or we've had patients who are really good at making it look like that needle is going in, but their insulin is actually just running out on the outside of their clothes or their body. And so if we're not supervising that closely, they could still be skipping insulin as a way to try to manage their weight. A lot of dietitians that we interviewed also reported a lack of formal policies. Whether or not they actually had those policies was an issue, but whether or not they had them, these dietitians weren't aware of them. And so that seemed to be an area where we had some concerns that those formal policies can help guide treatment and make sure everyone is being consistent across disciplines. And that the medical and biochemical monitoring can provide some checks and balances. So if we're checking blood sugars and A1C and ketones and these things consistently, it can help us verify that the patient is managing their blood sugar and their diabetes appropriately. And kind of back to the policies, 15 of the 18 clinical nutrition managers said they either didn't have policies or they didn't know whether they had policies. An interdisciplinary team is recommended for both eating disorders and diabetes treatment. And so it's, to me, even more important for patients who have a diagnosis of both. And I think allows a really great opportunity for the team to collaborate while still staying within their scope. You know, things related to insulin or blood sugars come up in my sessions all the time, but I'm not actually the one making recommendations of what their insulin to carb ratios and things are at meals, or that's our nurse practitioner. And so we can still address what we need to address without stepping out of our lane, but I think is really helpful for me when I know what's going on with their blood sugars and I understand how insulin works and I understand any fear or anxiety they have around taking insulin, and we can process that together and talk about how that's impacting their eating. Patients with EDDMT1 want interdisciplinary teams. They want their diabetes and their eating disorders to be treated together. As we saw earlier, none of the facilities, or I guess one of the facilities, excuse me, employed a CDCES or diabetes educator. And so for a lot of facilities, that may not be very realistic to have a diabetes educator employed full time, but maybe there's someone in the community that they can consult with on an as needed basis or bring in for diabetes education when they do have patients. And that patients with EDDMT1 have highlighted the importance of peer support in other qualitative research. And so that having a diabetes specific group to me would be an opportunity to meet these needs, whether that's in person at your facility or connecting with virtual groups in other places, and allowing them to have that space to meet with other people who have diabetes and talk about diabetes. We have a diabetes group here at the center that we do weekly with all of our inpatients, and we have a monthly outpatient group. And for a lot of our patients with diabetes, it's one of their favorite parts of the program because there are things that relate to their diabetes that they don't feel comfortable talking about in other group therapy settings, but that diabetes group is a really safe and appropriate space to do that. As far as feedback that we got of areas of improvement, these professionals want and need more education, not only in our research, but in other research. And so some areas where we felt that this could be appropriate is maybe doing in-service trainings. You know, there's probably a lot of turnover of nursing and care tech staff who are on the unit 24/7 with these patients, and even for other providers, just to have a basic understanding of diabetes and knowing what the program at your facility looks like. Webinars such as this or other ones, maybe attending conferences, and learning more about diabetes and EDDMT1, and also maybe doing one-on-one clinical supervision with other professionals in the field who may not be at your facility. So in conclusion, we felt that EDDMT1 represents a unique co-occurring disorder that requires specialized treatment by an interdisciplinary team of professionals, and that education is key. That was one of the things we got the most feedback about having more of. And I think even though, you know, I've been here at the center for a little while now, and I've worked on our diabetes team for most of that time, I feel like I learn something new every single time I get a patient with diabetes, because even though, just like with our patients who all have eating disorders, they are very different and have different needs. With our patients with type 1, they also have a lot of similarities, but their experience has been different. We'll get patients who have had diabetes their whole life and they had no diabetes in and out, and I've worked with other patients who got diagnosed 1 to 2 years before treatment and have no idea how to carb count and don't have a lot of these skills that someone else might. And that we also need to do more research to develop standards of care for treatment of EDDMT1 in a residential eating disorder treatment facility setting, and that if we could come up with more standards of care, hopefully people are getting consistent care no matter where they go and able to have those more positive outcomes with treatment and recovery. So that is all I have for y'all today. We'll turn the time back over to Tamara here in just a minute, but if your question doesn't get answered or you think of things later, you're welcome to, that's my email here at the center, you're welcome to shoot me an email. I'm happy to talk about it, and you all who also work at a treatment facility may understand how busy it is, so it may take me a few days, but I'm always happy to talk and collaborate. So thank you, I appreciate you being here. Let me stop my screen and I'll turn the time back over to Tamara.
Good, we do have some questions, so here we go. We do have some questions, so let's get going on those. Anna asked, do you have any recommended books to read about this topic?
Yes, that's a great question. So I should have brought them over here. One of them, I'll show them. Let's see. Here it is. This is probably one of my favorites. It's by Anne Goebel-Fabry, who, and I apologize if I butchered her name and someone knows better, but she does
No, I
a
think
lot
you did good.
She's done a lot of research about women with type 1 diabetes and an eating disorder. And so this book, she goes through a lot of her research and has a lot of direct quotes from women that she's interviewed. And so that book for our staff, I feel like was really helpful, but we also have our patients read that one too, and can be really helpful for them. I'm trying to think, that's the one that first comes to mind. I know too, I've gone to some of the conferences that the Diabetes Educator Association has put on. I've been to one of their national conferences and a more local one. And so those have been really helpful for me just to get more education. They've had some breakout sessions or things that are maybe more related to eating disorders, but even just to understand more about different types of insulin and how that works, and other diabetes management and treatment recommendations.
Thanks, Megan. I would also add to that that if you want to read a book from the patient's perspective, Quinn Nystrom has a book called "If I Kiss You, Will I Get Diabetes?" which is what her prom date asked her. Quinn is going to present for Center for Change. I think it's in August, coming up soon. I think it's just next month, on kind of that perspective, what it's like to be someone with type 1 diabetes and an eating disorder. So if you're interested in that perspective, again, it's If I Kiss You, Will I Get Diabetes? And it's by Quinn Nystrom, Nystrom.
Thanks,
Okay,
Tamara.
Megan, next question. This is also from Anna. Do you treat individuals with T1D and chronic kidney disease? How do you approach this where there is a need to minimize protein intake?
Yeah, chronic kidney disease definitely complicates things. I personally haven't worked with anybody who's had chronic kidney disease. A lot of the patients I've seen in the last several years are pretty newly diagnosed with diabetes, and so maybe it hasn't progressed quite to that stage. I think a lot of any chronic medical conditions to me that impact your food when you have a history of an eating disorder or disordered eating, I really like how intuitive eating, that last principle of honoring your health with gentle nutrition, approaches things. That there are certain things, right, with diabetes, you have to count carbs and you have to take insulin, and you may need to be skillful about the timing of your carbs or things like that. Just like someone who has food allergies may have to avoid certain foods or read labels, or be more cautious going out. And so I think if you do need to be more careful with how much protein you have, I think trying to approach that from a perspective of not, I'm always careful with my patients that we don't want to approach it of what do I need to restrict or cut out or be more rigid about, but maybe it's about timing, maybe it's about kind of knowing what my limits are at one sitting and the amount that I have. Maybe it's, how can I get more variety within what does feel good and works well and helps me be healthy in a non-disordered way. But I think that one, and maybe you need help from different people, that it may be helpful to see a dietitian who has a lot of experience with kidney disease, who's open to an intuitive eating or health at every size approach. But maybe you also need to see a therapist or dietitian or other people that are more eating disorder specialized, and kind of create your own collaborative team that has specialties and expertise in different areas.
Thank you. All right, Maria says, thank you for the very informative presentation. I wonder if you have any data in regards of management of EDDMT1 and risk of refeeding syndrome, and how the teams manage this risk.
That's a really interesting question. I don't have specific research on that. I know just in general with refeeding here, just from my clinical experience, a lot of the newer research, we found that we can be a little bit more aggressive with how high we start our calories, and we advance that. And the nice thing is, in this setting, we have 24/7 medical monitoring. So if we're starting to see any signs of refeeding, we can pause and back off a little bit. I will say at the beginning, a lot of our patients with type 1, maybe not specifically with refeeding, but we do want to bring their blood sugars down safely. And so we aren't super aggressive that we want their next A1C to go from 14 to 7. And that if we bring down their A1C and their average blood sugars too quickly, the research shows us that we may actually cause some complications and side effects like neuropathy and different things like that. So our nurse practitioner is really great about, having kind of, and there's research I think out there about how much to bring down the A1C per month or over so many months. And so it is kind of a gradual process, and we see less complications from that. But nutritionally, I haven't noticed a huge difference between my patients with diabetes and my patients without diabetes as far as how aggressive I can be with calories or weight restoration. A lot of it will kind of depend on how well their diabetes is managed. It's a lot easier to do weight restoration with someone who hasn't been skipping insulin than someone who has, because they just don't tolerate higher carbohydrate meals that come along with weight restoration and refeeding.
Rachel's asking, do clients need to be former CFC patients to participate in the monthly outpatient group, or is it available to anyone who would benefit?
Yeah, so our monthly group in a pre-COVID world, we were doing in person and it was really fun for all of our local people. And we would have dinner together and kind of have that meal support along with a therapeutic group. But since COVID, we started doing that over Zoom, and our marketing people are great about posting flyers and reminders for that online. And I'm usually the one that you email if you want the Zoom information for it. But we've been able to, since COVID, include people that aren't local and people that have been patients and people that haven't. So yeah, if you haven't been a patient, it doesn't exclude you. I don't know what that will look like when we're able to go back to in person, if we'll continue to do both. We're hoping we can keep as many people participating as want to. So, but at least right now we do them the second Thursday of every month at 6:30 Mountain Time over Zoom. And we, between our diabetes team, we kind of rotate between our therapists, our dietitians, our medical providers, and we talk about sometimes more emotional topics, navigating relationships with diabetes or stages of grief, sometimes more practical like carb counting or traveling with diabetes or how to manage sick days or things like that. So we try to do a wide variety of things throughout the year. But yeah, if you know people who are interested or you yourself are interested, watch for those flyers. They usually come up during the first week of the month, and then the group is the second Thursday of every month.
Yeah, so stay tuned to Center for Change's social media sites, and you'll see those posted there. We have more questions, but less time. So Megan, will you, and one of them is asking for your contact information again. And since the slide's not up, will you just remind folks what your email address is, and then they can email you if they have questions that we weren't able to get to today.
Yeah, so my email, that's probably the best way to get in touch with me, is Megan, so it's MEGAN .Austin, AUSTIN, so just like it is here on my screen with my picture, and then it's at UHSINC.com, so it's UHSinc.com.
Perfect, thank you. Well, we just want to say thanks again. Thanks to Megan for just fascinating information and a great webinar. And thanks to all of you for participating. 2 reminders before you go. When I click to end the webinar, there'll be an evaluation that will automatically pop up on your screen. If you would take just 1 minute to complete that evaluation, that would be really helpful. That's a continuing education requirement for us. It's completely anonymous, so feel free to be candid. We then tabulate those results and send them to the CE entities, and that's, again, a requirement that we have to do. So if you have just a minute to do that, once the webinar ends, that will pop up. That will be great. And then about an hour from now, you'll receive a separate email from GoToWebinar with the link to take the online test. You must take the test online in order to receive credit. Once you pass the test online, then your continuing education certificate will be automatically downloaded to your computer. If you don't see it on your screen, look in your downloads file because it could be hiding there. Thanks again, everyone. We hope you can join us next time. We have another webinar in 2 weeks on Wednesday, July 28th. It's Dr. Julian A. and Dr. Ashley Southard from A New Beginning in Arizona. And the title of the webinar is Inside the Mind of an Emotional Eater, the Deeper Work for Full Recovery. So we hope you can join us then. In the meantime, everybody, be well. Bye-bye.